Welcome, guys, to the Couple Nurses podcast with your hosts, Peter Findera and myself, Matt Solarchuk. This is a podcast where we tackle current health news and hot nursing topics one conversation at a time. If you find any value in this podcast, please give us a review, follow, and share. You have no idea how much that means to us, and it helps us rank better on the algorithms. More people see us organically, and what does that mean? Motivates us to keep on producing high-quality content. So thank you, guys. We're going to have a lot of cool things coming out. Of course, as always, we always make these announcements, but next week is episode 100. So we're going to do a special 2-hour special, or hour and a half for the most part. We're going to go into our life story about like how everything started, about nursing, the pandemic, us as a podcast, what we have in store, and then we're going to talk about drama in the workplace.
I'm actually really excited. Like, we're going to dive in from like day one of why we became nurses to how was nursing school to how is it being a nurse prior to pandemic, how is Midwest nursing different from California nursing, some drama, because there's always drama in the workplace because with all these, this female dominant field, it's interesting.
And we actually got caught up in some drama ourselves that happened because of social media. So I'm sure you guys are going to love to hear that story and how we kind of went through it.
Interesting. Shit's always going down.
Yeah. And if you're wondering why, if you listen to us on Instagram or watch our stories and you're wondering why we haven't been posting anything at work, well, that's exactly why. So you're going to have to stay tuned for episode 100 to know about that.
A little teaser. And guys, remember, we still got the Patreon going. If you guys like what we do, we have more great things on Patreon and more great things with less censorship. We do nursing debriefments on our way home from work. So we talk about our shift on Patreon. And then we do these That Loud specials on Patreon as well. It's called That Loud. So if you guys are on there, check it out. Some more content. And I like the That Louds. I almost like the That Louds more than these episodes.
Yeah, it's fun because you get to you're kind of doing whatever, saying whatever. You don't, care kind of about, you might offend somebody. You're just kind of like going straight off the dome, man. It's fun.
Yeah. But on today's episode 99, this is another episode where we're going to talk a good amount about C19, how it is nursing during COVID, how stressful it is, and just kind of our perspective and the things that we deal with, because COVID is still around. It's, even though the numbers are downtrending, there's still a lot of us for us to do. People are still very sick, and we're still managing stress, higher amounts of stress we're managing, and it's still pretty bad, man. Like it's bad, like especially with you and your ECMOs and stuff. It's tough. It's still super tough.
Yeah, this is the era of the COVID-19 pandemic, and the nurses are in this era, and we have to survive. Nursing is hard, just like you say. And I miss those times where we kind of like chit-chatted with our patients, man. Like 90% of our patients plus, man, are intubated. There's no communication whatsoever. Like, the slightest communication we get is maybe some following some commands, and that's really it.
But the hardest thing for me, well, not for me, just the hardest thing like in general, like the biggest change is definitely not allowing family in the hospital. That's probably the biggest move that's been made so far.
Yeah, change in dynamic.
And at the beginning, I liked it. At the beginning, I was like, for sure, no family. I don't have to deal with them as much. I won't have to deal with the drama, because when there's family comes in, there's usually 3 or 4 of them, and they're not really sure what to do. Yeah. There's a lot of debate going on. Somebody's really needy, and they keep asking you questions, and they're trying to figure it out, which I'm okay with answering and stuff. But sometimes it does get a little overwhelming. So it was nice to get that break, but now it's just like, you don't think I don't feel like it's worth it.
So yeah, I see your perspective. So it's like, at first it was awesome because family, that dynamic of family not knowing what to make decisions, it made work more stressful, right? Dealing with family. Now we're not dealing with family as much, but the care, I feel like, is different. Meaning families not realizing how sick these patients are, how much they're actually suffering day in, day out. They don't get to see them. And I feel like that's kind of prolonging care, and it's prolonging suffering. Just seeing COVID butt and all this damn stuff. It's like, yeah.
It hits differently. There's only so much you can explain over the phone without them being able to see it. And even though you bust out the iPad and you show them their loved one, it's different. Like, they're still not there in that present moment with their loved one, and you don't get the same kind of energy, the same kind of feelings, and it's so short-lived too. You can only have them be on iPad for so long.
Yeah, imagine
instead
if,
of them hanging out in the room. Because majority of the times, if someone is really sick in ICU, someone usually spends the night, or they go home at night and they come back in the morning, and they're usually there throughout the whole day. Here it's like nothing. Maybe you get like maybe an hour and a half, 2 hours of FaceTime, and that's basically all your contact to the loved one that's literally dying in that bed.
yeah. I remember last week is the first time I FaceTimed a family member in over probably like 3 months. No, actually 2, 3 months. Yeah. It's usually a day shift thing. Usually day shift FaceTimes. I got the iPad for the family. They brought their own. I called them and it's like, I'm like, are you guys ready? And I flipped the screen and then the patient's just there, dude. Intubated, trach. I'm not intubated, trach. Just the ECMO. Like he has blood coming out of his suction because his platelets are low. And right away, I just felt that atmosphere change, man. Even if it's through an iPad, like you just feel the energy, like the wife's face, man.
Like they talk to you and you're talking to them, and they seem okay, like they're fine talking to you because they haven't seen your loved one yet.
Yeah.
You haven't put the camera. So you're talking to them, having an over conversation. The vibes are okay. They're a little nervous, but everyone's still calm. They're maybe cracking a joke. They're talking amongst each other, kind of laughing here and there. And then once you flip the iPad, it's just like silence.
Yeah.
It's like, holy shit, this is how my loved one looks. This is my husband right now.
Yep.
Like, because you can't grasp it with words. You have to have a visual aspect of seeing your loved one literally in that bed, especially like seeing that blood and then the cannulation site, because it was in his neck, right?
Yeah, that's where he's getting perfused because his lungs are completely shot, and yeah, that makes it very hard, man. And
How'd they react?
well, the wife
Family.
the wife was praying, praying, and then she kind of shed a tear, and they say, come on, like you got this, you could do it, you're strong. It's like just those words of encouragement. And it's just like, that this patient's freaking critically ill. Like he has such a long road ahead. Like he probably needs a lung transplant because he can't do anything. But it's just like, they're just fighting on, man. What else do you have? What else do you have left if you don't have hope, And that's all that they have, because that's just good enough,
Yeah. It's crazy. He needs a lung. So his lungs are they're gonna fail eventually, right?
And that's what I'm trying to figure out with this whole COVID, man. It's like these lungs are so bad where we're giving them 100% on the vent, where they have an ECMO device, meaning they're cannulated, where their lungs aren't working, so their CO2 is getting removed artificially, getting pumped back into the blood, and for some reason their CO2 numbers are still high, not improving. So that means their alveoli are just completely shot, man. So at this point, what can you do? You need a lung, man.
Yeah, right.
You can't live on ECMO for the rest of your life.
Because there's nothing in your body that's doing the gas exchange.
Yeah, and if those that don't know, ECMO is literally like your artificial lung. It could be also an artificial heart. In this specific, it's VV, so it's venous to venous. And it's like, yeah, these patients can't move. We have to log roll them. They're cannulated in their femoral artery. It's sad to see.
It's sad to see, and it's a mess. And like you're like a decently healthy person that has to be put on emergent ECMO doesn't have a good survival.
Yeah.
In general, and like imagine you throw COVID-19 into mix, it's even lower.
And keep in mind, this is the perspective of ICU nursing, I understand in different units, it's just, you're still putting on the PAPR and gowning up, but this is just a little aspect of ICU that we're seeing, and it's tough, man. We got patients that lay there for 2 months. They develop COVID butt, meaning their sacrum is so compromised, their skin just literally slides off. It's a weird phenomenon. We call it COVID butt. And it's like, dude, these patients are pooping. They're covered. Their wounds are covered in poop, and we're trying to clean that up. And you're switching the dressings 2-3 times a shift because you're trying to help their butt heal. Like the Mepitel, and it's freaking tough, dude. If that doesn't scream PTSD to you for some, man, I don't know what is.
Sacral wounds are the worst because especially if like they're having diarrhea and stuff, they're never gonna heal. It's never gonna heal. How many times have you had a patient that had a sacral wound on a coccyx or anywhere on a butt cheek, and it just doesn't heal? You could take off all the pressure you want. It's really hard to heal because people have to go to the bathroom. Like they shit. And a lot of our patients unfortunately have diarrhea, because we give them antibiotics, we give them a bunch of medications that, give them diarrhea. And if it's on your sacrum and coccyx and your stool always getting in there, you're always touching it, you're always messing with it, it's not a good wound healing environment. And that's why these get so bad. And they get bad in general. And then like let's say with the lungs, where how COVID damages it, same with these wounds. For some reason COVID has, effect on slower wound healing, and it just these wounds progress to like very nasty ones, and eventually, Then eventually we can't do anything about it.
Yeah,
And they're not stable enough for surgery. Like I had a patient with a nasty ass coccyx wound where you could put your whole hand in there, and the only solution for it was surgery. But since he has COVID-19 and he's on so much medication and on full vent support, he's not stable enough for surgery. So it's not gonna get any better.
Yeah, and speaking of poop, like a lot of these patients have such low platelets because of what COVID does. Also, if you're on ECMO, it's circulating blood constantly, so that metal fan is technically breaking down your platelets. Their platelets are so low, they're bleeding out of nowhere. We can't put a rectal tube in because they're gonna bleed out there. Like we had a patient who needed a massive transfusion protocol because of a rectal tube.
Yeah.
You just nicked their artery, man.
Yeah, dude. It's crazy, man.
And then also, I feel like COVID was just a giant experiment.
That's what
meaning-
it feels like sometimes. It
does.
still is. I mean, which like COVID is a giant experiment on like a giant perspective, like how on like a societal perspective, it's experiment in a sense where if a pandemic were to occur in the U.S., how would we deal with it?
Yeah.
We're kind of testing the waters, masks, lockdowns. That was a giant experiment on a social level, but there's also a giant experiment going on in more of a direct level to me and you. We're in the hospital.
How to treat it.
Because we still don't really have a 100% way to treat it. We're still doing like the remdesivir, and then we're doing the steroids, heparin usually, or angiomax, like things like that. We're still doing for like standard practice, but nothing. We don't really have anything definitive that fights the COVID-19.
Just like at first, they, you said there was Regeneron clinical trials, and then there was some clinical trials with the drug was called Sarimulab, whatever. It was the ILC inhibitor to see if it's trying to prevent that clotting cascade from happening from the cytokine storm. So they keep testing things, and I think there was another patient that they signed up for a trial and they're testing stem cell research on him. They're giving it IV to see if we could prevent ARDS somehow, maybe help alveoli get recruitment again and start perfusing. It's wild, man.
Yeah, even with proning, like we do proning for severe ARDS, and we're like, all right, well, let's try for COVID-19. Has it worked for some people? Yeah. Has it been very effective? Not really. Even the ventilator settings, one of our physicians was trying to see if a certain ventilator setting worked better for COVID-19 patients compared to another one.
But yeah, she tried doing bi-level ventilation.
So it's probably interesting. It's interesting if you're in a hospital where they do research, or you're in a place from a physician standpoint where you're allowed to kind of conduct your own trials like that. That's pretty cool. That's like something that is very interesting. Like you're able to, and this is not going to come very often. Hopefully, it doesn't happen again. But as time goes on, this is going to be kind of more prevalent.
Even like vitamin D. I think they started adding vitamin D and the zinc to like the MAR for patients to just take daily. Correct?
Yeah, because they added to the CDC guidelines like 2 months ago.
It's been over 2 months.
Vitamin C or vitamin D.
Winter of 2020. Yeah,
so 3 months. Well, it's February, so probably like 2 months, right? 3.
Somewhat like that.
Yeah.
And then also like it's interesting seeing these patients on like ECMO, and they need anticoagulation. So at first, when we got these COVID patients, we need to coagulate them. So the standard was heparin, and they still give heparin in some hospitals, but we've realized that these heparin causes hemothorax sometimes, right? It was causing crazy bleeding. We gave so much oral care to these patients that they were just bleeding out of their fucking mouth. I'm swearing because it's so wild. Like we're just stuffing towels underneath their necks to stop bleeding, and it's just bleeding out of their mouth. Like we can't control it. We're giving platelets, but it doesn't matter because the ECMO machine is eating these platelets. So then we switched over to Angiomax, which is a different type of anticoagulant, and that was a little bit more. It was better than heparin, and it caused less bleeding. And that's the experiment where we just didn't know how to treat these patients at first, and we kind of just used what we had, and we just kept adjusting, man. And we still don't know.
Yeah, that's kind of how it goes. Like, patient comes with COVID-19, they're more prone to clotting, so we got to put them on some anticoagulant. So let's go to like the first line is heparin. And that's kind of how you figure out what needs to be improved next. You got to tackle, hey, what are we gonna do for COVID-19? So this is our standard treatment that we're gonna do. This is the standard practice that we're gonna do. And now, because of the standard practice, great, you have a nice kind of like a baseline.
Yeah.
But then, since we're giving medications, and people are going to have adverse effects of these medications. And when you're giving anticoagulations, the number one adverse effect is going to be bleeding. So once you get a baseline of how to kind of tackle COVID-19, then you can kind of tackle these other issues that stem from not maybe COVID-19 directly, but from them indirectly.
Yeah.
Because them having COVID-19 requires them to be on antiplatelet medication or anticoagulations. And then because they're on anticoagulations, now they're bleeding. So now, hey, so we tackle COVID-19's coagulation issues. Now we got to tackle these coagulation issues that are developing because of heparin. So now we do angiomax.
Yep. And that's a lot of these patients too. It's like right now, the patients that are there for maybe a month or two or 20 days, like they're not fighting COVID really. They're just fighting this systematic issue that arose from COVID, whether it's like, their diabetes that were their underlying conditions have caused a lot of issues. Their hypertension, right? Where we have decreased wound healing. Now they have pneumonia. So they're not dealing with COVID. We're just fighting pneumonia now. Now we're checking blood cultures. Now they have a multi-resistant infection in their blood. Now we're giving antibiotics to that. They're septic because of that, that bacteria. Now their kidneys are giving out. And it's like we're always chasing something, and it's not even COVID anymore. It's just these other opportunistic infections and things that happen along the way of trying to save you from COVID.
Yeah. The problem with society and even like ourselves to a certain point is we don't really seek help unless we really need it or it changes the way we feel or it disrupts our daily activities.
Yeah.
Because hypertension, diabetes are silent diseases. You can't tell when your sugar is really high. You can't. You could be chilling at a sugar of 230, 240, 250, 300, and you could just...
For years, probably.
For years, and you could just live a normal life. You could go along doing things. You could be hypertensive for 5 years, 4 years, not realize it. Yeah, you'll get a headache once in a while. You might feel off once in a while, but you won't know you're hypertensive. Like I don't know when my blood pressure is 140. You don't. And that's the problem is people don't go to see the doctor, or they kind of push things aside for too long. And then something like this happens where it disrupts society and disrupts health, and you're the one that's going to be suffering for it because unfortunately you haven't taken the steps to take care of yourself on that level. Just because, you feel okay every day, and, you might have a few bad days in a row and you might hurt yourself here, and then, you shouldn't be eating that, but you eat it anyways. You should be doing more exercise, but you're not. And you don't see a doctor every week. You don't see a doctor every month. You don't see a doctor every few months, right? There's nobody there consistently telling you to change, right?
Yeah.
You yourself have to take that action to change the way you eat, to change what you eat, to change the way you do things. Imagine if you were required to see a doctor every 3 months, and that doctor told you every 3 months, hey, you gotta stop eating junk food. Hey, you gotta exercise. You'd be more prone to doing that, right? Compared to seeing a doctor maybe once a year, maybe once every 2 years, and him telling you, hey, you have hypertension, we're going to give you this medication. And now you see a doctor next year, hey, you still have hypertension, we're going to increase your dose.
Yeah, and
right?
it happens for years on, and people just miss it. And
prevention's hard, dude. Prevention's super hard. Like, if we could find a good way to instill prevention in modern society, I feel like we could take society into a whole different level. But we have to create prevention. We have to instill prevention in like a subtle way.
Yeah.
Because no one's gonna want to go to a prevention clinic every week, right? It's gonna take too much time.
I think it also is going to come from our leaders, right? Our leaders, aka our representatives of the people, right? Mm-hmm. They haven't, like, I was very optimistic with this pandemic at first, like in March, April of 2020. I'm like, wow, this is very self-reflecting. I have time for myself, whatever, self-growth, right? I thought a lot of people are going to wake up and change their ways and like, hey, these, like COVID, the reason why it got so bad is probably because of all these underlying conditions that we had in America, the change of our food pyramid in the 1970s, and we have this rise of obesity. If the government were for the people, correct, they would basically implement these things that you mentioned. They would help with prevention medicine. They would tell people that exercise, sleep, and diet is fundamental for us, and that we should all have accountability in ourselves. And we just can't rely directly on pharmaceuticals and doctors for this.
Right.
Is that happening? What do you think, Pete?
I feel like
it's hard, man.
It's super hard. I feel like there was definitely people out there that, due to COVID-19, they changed their lives for the better. You can notice that at work. There's a few nurses. Yeah, even at work, there's a few nurses that are trying to eat healthier. They're a little older. We do see them eat not healthily, but once in a while we see them
throw salad in.
Yeah, once in a while we do see them eat something healthy, and they try. They put the effort in, right? That's kind of what it is. Like, you put the effort in, and then the more often you do it, the more effort you put in, then it becomes a habit. Usually takes like 30 days, like, whatever. But at least some of them are trying. Is it as big of a change as me and you would like it to be? Definitely not.
Yeah, and that's my problem is that we always tackle the media because the media is a huge problem in this. They're not tackling the things that we mentioned: sleep, diet, exercise. They're tackling masks, vaccines. Things are bad.
Trump.
Fear.
Yeah.
Trump, of course. They're trying to freaking impeach the dude instead of worrying about real damn issues like people that are unemployed and still suffering from this pandemic, like small businesses, right?
Yeah.
And also, I feel like the government kind of left us hanging too when it comes to the frontline crew, all the nurses, right? Like, pandemic started, we got some, glory. A lot of people took Instagram photos. The news kind of made us feel like we're all this awesome needed crew, and we are, but that's it. How come real changes weren't made? How come changes weren't made to our PPE, to our supplies? Maybe the way hospitals are staffed. Maybe nurses are more stressed out than ever. How can we help the nurses? None of that shit. No. Here's some food. Here's some pizza, but continue doing more with less. Yeah. And that's what's been happening, dude. Like, you know how annoyed I am working a 12-hour shift, constantly looking for things. Glucometer's missing. Okay, it's the weekend. Now there's less supplies. I don't have the proper dressing that I have to put on my wound. Now I got to freaking put 2 different little dressings. Now my wound is a little bit exposed. Little stress that adds on daily on my shifts because of lack of supply and lack of I don't know, how would I say it? Properly, not staffing, but giving enough focus onto the front line.
And it would seem more upsetting because like we're in the ICU, so we like our control.
Yeah.
And that one dressing not being there, dressing that you always use because it works the best, that not being there, it just agitates you that much more compared to being on a floor where you kind of be more lenient, because
Right.
Because the big part of why people go to ICU is because they like to control. We like to control blood pressure. We like to have our patient the way we want them to be. We want everything to be crisp, to be on point. We want the blood pressure between this and all that jazz. And that one dressing, it might not seem like a big deal to a lot, but it could just piss you off a little bit.
Right.
And it's super annoying. And the staffing, I don't understand why staffing is such an issue, even here in California, because we're still short-staffed in our unit. Is it because there's a shortage of nurses? That's what I never understood. I feel like there's so many nurses out there looking for jobs, and yet like we're still short-staffed. Is there really not enough nurses to staff these positions? Like, what's? Like,
I think it's more
process.
It's from a cost perspective, dude.
Yeah.
If business, because hospitals are businesses, right? If they have these quotes, these standards, do you remember like if you like got rid of 2 patients, they sent you home and they shorted you to keep staffing? Like they have their they have their fiscal years and they have this criteria to meet how many nurses could be staffed, and that's it.
Yeah.
That has to be changed. Maybe you need some funding from a government to change that. I'm not an expert in that field, but we need some change, bro.
Yeah, they want to keep nurses safe and units safe, but with a cost.
It's fucking
crazy,
unsafe
dude.
right now. Let me tell you that right now. I don't care if we could argue that. It's completely unsafe. It's the Wild West in nursing right now.
Yeah, I just wonder how it is because we're here in California and, it's a lot better here than in other places. So imagine if we're struggling. I mean, I don't know. I wouldn't say we're struggling, but it's a little harder here than it used to be. And imagine how it is in other hospitals in like Texas and Florida where they don't have these mandated ratios and aren't as strict with the nursing laws.
See, so we're coping well, right? Like we're doing just fine. We have this podcast that kind of puts our energy away from our emotional energy away from, the hospital and what's happening, right? Like COVID. But like some nurses, they're struggling emotionally. That's another thing during this pandemic that we've been seeing. These nurses they have PTSD. They're stressed out. They're burnt out. They're missing shifts. They're calling in. They're even complaining to management, and a lot of nurses feel like management's not looking out for them. They feel like it's an emotional burden for them.
They take it really hard to the heart. There's a few nurses on our unit that are literally everything is taken to heart. The slightest thing, even if it's not in their control, they take it to their heart. Like they feel like they failed their patient.
Right. It's like, there was a patient that the nurse got on shift and he started having dark starry tools, meaning he's either bleeding internally and that's why it's black, or it's old, right? But right away she took it, oh my God, every single time I pick up a shift, I have a patient, something like this happens, and they're internalizing it way too much.
It's hard. Like, luckily, Matt and I, we have a really good work-life balance where it doesn't affect us. Like, don't get me wrong. There's times where I have a patient and it hits me, but I feel like I get over it within like the next day. Maybe I'll take it home with me for the day. I'll go for a walk, hang out for a little bit, like think about it, be sad for X amount of hours, but then I eventually get over it. It doesn't take me very long. Like I said, maybe a day. But there's nurses that are constantly in it, outside of work, inside of work, just thinking about their patients. Like, hey, Dan, what have I done this? I should have done this. Why did it happen? And then there was even talks at one point during huddle that having the same patient for 3 shifts in a row isn't a good idea, because that's how badly it was emotionally for some of these nurses to be with the same patient for 3 days, taking care of them, which is supposed to be more beneficial because you have the continuum of care.
Yes.
They were getting so emotionally hurt and emotionally attached and emotionally invested into this patient where it became unhealthy. It was healthier to break up the patient care to somebody else.
Yeah, just so they don't build that emotional tie with them. And it sucks, you have this patient that was there for, 2 months. He's doing really good. He started talking. He's off the ventilator. He has a trach. He's able to finally communicate, say his words. He's finally able to grab his hands. You have no idea, guys, what a positive experience it is finally having a patient that follows commands in the ICU, that nods their head if they're in pain, because it feels human again. And then all of a sudden you come back next to work, you tell the family how great he's doing, then he codes.
Right.
And people just internalize it. And that's one thing I've realized, that even with this pandemic, we can't internalize it so much. We have to take things away. We need that emotional off switch where we need to properly cope with stress. You have to do, something positive for yourself every single day, and take things away. Let's just say something shitty happens at work. Acknowledge those feelings, right? It sucks, right? See how that feels, but continue, because you can't let life like that drag you down, dude, because it's going to make you depressed, literally.
Yeah, the hardest shifts in nursing I've had was 100% when I've had the same patient for 3 shifts in a row, or the same patient for 2 weeks or 3 weeks or the month that he's in hospital, and they just don't get any better. Like they
keep declining.
They just keep declining, and you're there for the whole decline. You're just like, dude, I'm starting new drips one day. Next shift I'm giving blood. Next shift I'm trying to reverse the Coumadin because it had an adverse effect with a medication. So every day you're doing something, and you're working a whole shift, and everything that you're doing, it's just decline. Yeah. And just like, dude, like you feel hopeless and you feel almost like worthless.
Yeah, it causes you to be negative.
Right, like I'm here, I'm a nurse, and my number one goal at night shift and becoming a nurse is to help people and to make them better. And I can't do any of those roles, and I can't even talk to this dude. And it just takes a giant toll, because there's literally nothing in your power, and you're doing so much stuff in those 3 nights that you have him. You're continuously doing stuff, and it just doesn't improve anything.
Yeah.
And you're just like, damn, shit, like fuck my life. And then you have those times where you have him for 3 in a row, you're off, and you get him back, and you help, and you're doing your nursing care, you're taking care of business, and you get a little better. You're like, okay, for sure, maybe he's turning around, and you come back next shift, and he's going down the whole game. You're just like, God damn, dude, he was doing a little bit better. I thought, we're improving him, and then you're back, and damn, next day, back down the toilet. You're just like, fuck, dude. Like I'm doing everything that I can in my powers. I'm literally doing everything, and he gets a little bit better. We get excited. Physicians get excited. All right, we're gonna change up the treatment plan. We're gonna change up the treatment that we're doing. We're gonna give him different medication, and next day, bam, down the shitter. You're just like, fuck, dude.
Right. And now let's add management, where a lot of nurses don't feel support from their management, right? Like they're just left hanging. And add both of those stresses. It's like, dude, why do you want to even work at the hospital, man? We had some nurses there, new grads, that don't want to do bedside nursing. They want to just take a little break and see what else is there. Not everybody could handle it, man.
Like regarding management, like I've never had a bad experience with any management. It's probably because I do nights, and you don't really have that communication with management. Yeah. How often do you talk to your manager? Rarely. Maybe, he brings up a point of something that wasn't done, or something that we're changing, or something you got to do differently, or just have a really quick little conversation with him about something. That's about it. Yeah. You don't see him every day, so you don't have the interaction with him.
Yeah, but see, we're both dudes, right? We care less about this.
Yeah.
We are travelers, so we're out of the politics. But
even in my prior hospital.
Yeah, but staff nurses, and then we see that as an example in our hospital. What they're going through, how there's this whole day shift, night shift dilemma. They're just, tied up in drama. This is happening, that's happening. Why do I have this patient? I can't switch days. Oh, this is, what I mean? There's always things being added on, and they don't feel, if you don't feel like love from your leaders, you're gonna fall apart, man. It's like a lone wolf situation, and everybody's just out their own, fighting every single shift, trying to survive and make it.
Yeah,
it's not
rough,
sustainable, dude.
You know what's really annoying too, man, with this whole COVID-19 is just the amount of gowning you got to do. Like gown on, gown off, put the PAPR on, put the N95 on. Like that just gets super annoying, dude.
Yeah.
And yeah, like cluster care is really good. And during COVID-19, we're doing like super cluster care because, dude, it's rough gowning up, gowning on, and then being in that gown and a PAPR for in a room. And sometimes, you're in that room for an hour, given a bath. Dude, there's been a handful of times where I gave a patient a bath, and then I realize I sit him up, and all I see is him laying in shit again. I'm just like, damn it, I gotta change him again. And sometimes you're in that room for like hour and a half, sweating, dude. Like your nose is starting to itch, and there's nowhere to help. You're just like, damn, I just clean this guy up, change the sheets, and now, dude, I put the chuck a little too high, and now I gotta change the chuck and the sheets again. And you're just like, damn, dude. And sometimes, I'm not gonna lie, sometimes, just that fact that I have to gown up and gown on and be there in that patient's room for a while, I kind of, it's gonna sound kind of shitty. I kind of put that like to the side for a little bit.
You have to,
like, like I don't go in the room as quickly as I would if it was a normal room, because you kind of gotta cluster more, because you do have two patients in the ICU and they're both really sick, so you can't be in one room for an hour and a half, because who the hell knows what's gonna happen to your other patient.
Plus, you're putting yourself at risk.
Plus, you're putting yourself at risk. But we talked about this more like a little bit ago, where our patients are intubated, sedated, and their spread for COVID-19 is really low if you think about it, because it's a closed system.
Yeah, plus it's a negative pressure
room. And it's a negative pressure room. So if that's were to pop off, if they're to pop off the vent and, exhale and or inhale and, breathe, yeah, I'd probably get infected. But if I was not, if I was not wearing an N95.
Yeah.
But I have to be pretty close to them, because the negative pressure room would supposedly be able to, combat that aerosolization and stuff.
Speaking of being in the rooms, I think that's another thing that's difficult, is on top of gowning is the lack of resources, where you're in this room, like back in the day, last year, right? Hey, Pete, come help me, give me a quick turn. Boom, you hop in the room, quick turn, no big deal. Now it's such a process. Sometimes you feel bad asking another nurse to come in, because it's, they have shit to do. Right. So you're there alone in the room doing a lot of care. You're trying to turn and manipulate, stuff a pillow. Like, we're prone for injury now too, man. My back.
Super prone.
Putting this, those little slippers, the little booties for the shoes. God damn, you know how much times I almost busted my shit? You almost did too with those booties.
I had a sprained ankle at work, and I made it worse with those booties. So I don't wear the booties anymore.
Yeah.
Like, dude, those are slippery, man. Like, it's scary, man.
Yeah, it's scary. I'd rather have dirty shoes at that point. Yeah.
And plus, we even wear our shoes to work. We have work devoted shoes. And then I forgot what I was gonna mention. Oh yeah, with the whole injuries, prone to injuries, I have never done this much bathing, patient care, turns, adjustments by myself ever. Because I just sometimes you go in there, and the patient looks not too heavy, and you're just like, damn, they're heavier than they look.
Yep.
And then you go outside, turn around, and nurses are in the room. There's no runners. Just like, damn. Well, I guess I got to Chanelberg him and just pull him up myself. And that's what I've been doing, because everyone's so busy. Dude.
How much times have I done it where I just clear my lines? I go to the front of the bed, and I'm just trying to drag my patient down the middle a little bit higher in bed, because normally we go side by side and there's just no help.
There's no help. Yeah, so you got to do Chanelberg, have them slanted on an angle so it's easier for you to pull them, and then that's it. Like, and it's like there's been times where at work, probably like I want to say last week, where I had two patients and they're both pretty heavy, but not heavy enough where I need help, but just heavy enough where you're definitely getting a workout in when you're boosting them and turning them. And then after that shift, I took a break from the gym. I'm just like, I'm not gonna work out today because I'm just exhausted physically.
Right, just like you mentioned, man, putting these gowns on. Like, guys, I walk out of my room sometimes, and all of my hairs on my arms are just like covered in sweat.
Yeah, because you can't wear a gray shirt to work.
You cannot wear gray shirts. No.
If I wore
whites.
If I wore a gray shirt and a gray pants, if I wore a gray colored scrub set, dude, people would think I'm pissing out of my ass, dude. Like, I have a bunch
of SWASS everywhere.
First of all, I get SWASS all the time, especially if I'm on caffeine. It was funny because we wear our scrub colors are like green or whatever, like green. And then I remember one day I drank a lot of coffee, and the beginning of my shift wasn't super busy, so I was sitting, and like I knew I had SWASS. So I was
wet SWASS, just for people that don't know.
SWASS is a sweaty ass when you wear certain color pants. and you get sweat on your ass, it bleeds through your underwear, and then you can see the sweat on the behind of your
Bleeds
scrubs,
through,
your
bro.
pants.
Pete needed a tampon.
You know what I'm saying? Yeah. An ass pond at this point, you know. And one day, like it was super busy, so I was kind of hanging out for like the first like half hour. You know, I was able to kind of relax, look at my notes, and I was sitting, and I was hot. Like I felt like I was hot. Plus, I was wearing a long sleeve underneath because you know I have tattoos and I don't want to always show them. And then plus I was wearing that underneath and a t-shirt, and I was sitting down and I was drinking coffee, so I was hot. And I knew I was getting SWASS. I just didn't know it was that bad, so I decided to get up, walk around, and then one of the chargers is like, "Hey Peter, did you sign something wet? Because your butt's wet." I'm just like, I was like, "No, it's probably just my SWASS," you know. And I was like, "Damn." I went to like to the bathroom in the mirror. I'm just like, "Yeah, this is definitely noticeable SWASS, dude. I'm gonna tell people that I signed something wet in that case." And it was just funny.
It's a little embarrassing, but it's part of the.
This was like 2 months in, you know, and she laughed at me, and I was like, you know, what am I supposed to do?
It's the worst, bro. Speaking of SWAS, like that's the worst where like you just had like a bunch of caffeine and you're heated, or you just came out of the room and your body's just, you know, hot, and you sit on one of those like leather rubbery chairs, and when you sit down, there's like this, you know, nice little imprint of like butt cheeks.
Yeah, it's so funny. If you see me coming out of a COVID room and I'm standing on the computer, it means I'm warm and I probably have SWAS, so I can't sit down.
You can't sit down, man. You gotta let your body cool down.
Yeah, because as a nurse, you're on your feet all day. Like you don't sit in a patient's room. Like you walk around nonstop. So when you chart, that's your chance to sit down. And usually I chart sitting down. But if I'm charting standing up, it's because I have SWAS and I can't sit down because then I gotta. It's gonna be an imprint, you know.
I don't know, man. I'll point it out next time I need, man. Yeah. It's also wild. Like a couple of days ago, we had a nurse. He's a travel nurse, but like within 1 hour, both of his patients died. Imagine that feeling. Like he managed well, you know. But imagine having like a female, like one of those like coworkers are very emotional. Like, dude, that's hard, man. Yeah. Like I have never bodied so many patients in my life till COVID.
Right. Imagine if one of our more emotional coworkers had that pair.
Oh what?
Yes, one of our more, and you know who I'm talking about.
Yeah.
Dude, she'd probably cry. She'd for sure cry. She probably wouldn't know what to do. She'd probably take like an emotional break for sure. Imagining.
It's tough.
You know?
I know how to bag my patients with my eyes closed, as effed up as that sounds.
Yeah, dude. And those patients that did pass away, I had those prior, and like one was doing better and low key, like he was improving. And it was one of those things where my dumbass went into a room, tried to be, you know, an extra nurse. Let's give him one more turn, and because the thing is, I'm sorry, I don't mean to laugh or anything. It's
funny looking
it's a bad
back
predicament.
at it.
Yeah, but it's just kind of goofy looking back at it. Where all night, so sometimes with these patients, the guy had 2 chest tubes, and the nurse during days told me, hey, he doesn't like to be turned on one side. He doesn't do very well on one side. So I was like, okay, for sure, I want to turn him on that side. So I was laying him flat, and on the other side, the majority of the shift, going back and forth. But then at like 6 o'clock came by, I'm just like, I was kind of curious. I'm like, damn, I've only been turning him on 2 sides. I wonder if he's still gonna crash if I put him on the other side. And decided to put him on the other side at like 6:15, 6:30, and then we couldn't get his stats up. We started crashing. I'm just like, fuck my life. So
right before he changed his shift.
Right before he changed his shift. So I'm just like, damn, fuck, F my life, dude. Like he was getting better, dude. He was getting better. Stats were good. We added the flow vent. He was improving, and then I had to go in there right before I left to stir some shit up when I was told not to put him on that side. But I had to see for myself if it's going to be if it's actually going to happen.
Yeah, and it did.
And unfortunately it did. But I took a gamble, and I mean, I don't feel like I don't feel like I'm the one that killed him or anything like that. You know, he was still alive, and he passed away, a few days after that. But like me doing that turn, that wasn't the cause of him deteriorating and dying. It was gonna happen eventually.
Yeah, but some nurses can internalize it like that.
Exactly.
They're like, oh my gosh, if I didn't put that pillow there, he would have been fine.
Right.
And they just take it to heart like that, and that's what messes them up. And then they go home about this and they think about this. What could I have done differently? Why didn't I do that? Wow, I'm so stupid.
Right.
It's that negative talk, man.
Yeah, and it's just how sometimes it happens. It just shows you how fragile life is, where literally putting a pillow under someone's back on one side can drastically perpetuate their decline.
Yeah, I have 2 great quotes from NBC News from like frontline warrior stuff that I have in here that I should read off. I think it's pretty powerful. One of them is, just imagine having to make decisions every day on whether you're going to fulfill your professional obligation to take care of patients versus sacrificing your personal safety or even that of your family because you're in a situation where you don't have adequate resources, right? That's one of them. And then think about this perspective. We didn't sign up to be sacrificial lambs. We didn't sign up to fight a deadly disease without adequate resources. We were told we are soldiers. Well, you don't send soldiers to a war without a gun and expect them to do their job. But you are doing that to us. And that's exactly how it's been, kind of felt during this pandemic. It's just like, dude, we're in this war with COVID, and it's like straight up out of a freaking movie. Like in those movies where it's like quarantine and everybody's kind of like sick, that Ebola situation almost right in movies, yet we don't have adequate resources, and the government's just looking the other way during this time, I feel like.
They're more focused on, Trump's lawyer case or whatever, dude, and
they needed us when they needed us, which was to kind of blow this up a little bit, and they did, and they used the whole, oh my God, N95 and my lips are, my face is bruised and all that. They used it for that, just to show how bad it is, but that's all. Did they help?
No, and same with the vaccines. Who gets them first? The frontline warriors, the frontline workers get them first. You guys get them work. You guys get the vaccine first because you guys are taking care of them. We got some hype for that too. We got hype in the beginning of COVID during unknown times, and we got hype, mid-COVID with all the stuff that we're doing, and now we got hype during the vaccine. It's just to kind of make us just when we're going down and we're trying to start fighting back and start kind of pushing our way, they give us a little bit of more of a push up.
Yeah,
you know what I'm saying. And it's just how it is. I mean, maybe now people will be more inclined to push for better patient ratios because we've seen the negative effects, and we've seen how dangerous and how hard it is to work without ratios. So maybe these states that didn't have ratios or that weren't as prevalent as they are in California, they might start pushing for them now. But what's going to happen post COVID-19? Look, with COVID-19 was also like a giant nursing experiment too, to see how much work can we add to nurses until they reach a breaking point. And that's gonna be the gauge for staffing. Like, hey, you guys were able to deal with this during COVID. Now it's not COVID. You should be able to deal with it easier because they're not as sick. I hope it's not gonna be that kind of bullshit.
Oh, better not, man.
Like, hey, you guys did it during COVID-19 and it was a lot harder. Now there's no COVID-19. It should be a little bit easier, shouldn't it?
Yeah.
Well, yeah, no shit, but the workload is still the same. You're just putting a different name on it.
And that's why, like, the next episode, when we talk about, like, what we want to do with couple nurses, like, yeah, man, we need to, like, start having a voice for nurses. We need, we need to implement real change. Yeah. It can't be change on social media of, like, this is tough, oh my God, but, like, that's it. Because that's that victim mentality, right? We just get recognized for our hard work, and that's it. Mm-hmm. There's no real laws or things in place. Even patient ratios, like let's just say, for example, Illinois. Why wasn't it changed? Because the American Hospital Association was lobbying to prevent patient ratios for nurses. Why? Because it's not costly. Right. They can't fit it in budget.
Mm. Yeah, but the CEOs are still getting these nice paychecks of 6 figures, 7 figures. They can't take a pay cut. The CEOs can't take a pay cut. The CEOs get paid mad amount of money. Yep. You're saying you can't downgrade your lifestyle from, let's say if you make $5 million, you can't downgrade your lifestyle from $5 million to like 4.8 or 4.5 for the benefit of society and benefit for your hospital. Like, how does that make any kind of sense? It's so weird, dude.
And I'm not saying we should go and like strike and leave out of the hospital and not have patients take care of, but that's the power that we have. And when nurses unite, they should be able to feel that out, where we are tired of this. This is enough. We need change, and it stops now. We need that voice. Yeah, Peter, we need to be the leaders. Are you ready?
Are you ready? Nursing is hard because, like, if you're like a plumber or an electrician, you could all leave and strike on your job, and no one's gonna really die directly from a result. As nurses, if me and Matt were to say, hey, we don't like the situation that we're in, we don't like the ratios, we don't like how this unit's being run, we're gonna leave, we're gonna strike. Well, guess what? We're making that unit 2 nurses short. If you make that two nurses short, people might die. If a whole unit of nurses leave, that whole unit's gonna die.
Yeah, Pete, that's the freaking problem, though. The problem is that these people, these higher managements, they know that nurses have their license on the line. Yeah, patients' lives are on our hands and our license depends on it. Therefore, we always take so much shit because we know that this, like, dude, as a nurse, you're never going to want to jeopardize a patient's life.
Right.
So what do? You always do more with less.
Right.
You always get the short end of the stick. For how much longer?
Yeah.
Shit pisses me off, dude.
It does. So I'm saying, hopefully after this whole COVID-19, people realize, maybe management realizes, hey, dude, like, maybe we should staff accordingly. Maybe we should not think about the money as much, and we should maybe staff these units appropriately, dude. Because as nurses, it's like we're very compassionate. We're very passionate about what we do. And our number one goal when we enter work is our focus goes from focusing on us, on our external life, on our friends, our family, and it goes 100% flips to just the patient.
Yeah.
It's just the patient, and that's literally all that I'm thinking about for that shift. And that's very easy to take advantage of because there's no way in hell I'm going to walk out and protest or walk out and do anything during that shift. I won't. Like it's no matter how much you throw, no matter what you throw at me, no matter how busy my shift gets, I'm not gonna say, hey, this is too much and leave.
Right.
Because it's not. Because the fact of the matter is, it doesn't affect my life when I leave. It's going to affect the patient's life.
Yeah.
And that's the crazy thing about it, is we're so selfless at work. Is that you're willing to sacrifice your life, you're willing to sacrifice your mental health, your physical health to help that patient out.
And we've done exactly that.
Yeah. And burnout is you devoting your whole shift to these patients, and you doing that consistently day in, day out, and that patient dies.
Yeah.
That's like the key burnout is these lack of ratios that requires you to take the burden. And not only are you taking an emotional burden for the patient because the patient can't talk to you, he can't express himself. So even though he can't express himself and he can't tell you how he's emotionally, you feel that energy in the room, and that energy you take in.
Yeah.
You take in that patient's feelings even though you can't explain them to you. And same with the family. You're also dealing with family and you're getting feelings from them. And you're not having your feelings anymore. It's not you at the hospital. It's just your body is there, but it's not your personality. It's not your mind. It's just like the thoughts that go through your head is just a composition of everything that's going on in the hospital at that point in time.
That's deep, dog.
And that's how selfless we are in the hospital.
Yeah, nursing is a weird profession where, just like you said, you just take away your whole life is put away somewhere else. And you're here with that patient for 12 hours. It's such a weird experience. Yeah. You don't give a shit about yourself. You're holding your urine in. You're not peeing. You're not drinking enough water, so now your urine is yellow. You know what I'm saying? You're not eating. You're hungry. Oh, there's no breaks. Shit, I didn't eat for 6 hours sometimes beginning of my shift. No, you know what I mean?
Yeah.
It's just, yeah, where are these boundaries, man? And as a leader, looking at it, and maybe you're a manager, you're listening to this, it's like buying food for nurses is not the solution. You're just kind of giving us a little dopamine rush while we're in this shit, while we're in this pile mess that we can't get out of, that we have to somehow. It's a pandemic, I get it's going to be rough, right? But things could be a lot better if we handled it properly from a government standpoint, from a leadership standpoint in the hospital, and from ourselves, right? From taking accountability, from not taking things so emotionally, right? So it's even like drama in the workplace, right? It all stems from the values that you have onto yourself, and you project that as a perception into the hospital setting, right? Yeah. So if you're a dramatic person, you're going to always be seeking drama in the workplace because that's all you know. You know the familiar. The familiar is good to you.
Yeah, that's true, dude.
And we've been so adapted to this familiar, which is a stress. And we as nurses haven't said shit about it because it's our familiar. This is nursing. It is supposed to be rough.
And it's fortunately a bad coping mechanism, but this is how it is sometimes, man.
So, yeah, and I feel like we are where we are with nursing because of everything that's happening. And we have to quit that bullshit of, oh, this is just how nursing is. It's rough. No, we need some freaking proper change, dude. Just like an older patient, right? They always tell us if an older patient... I'm sorry, let me reword this. It is not normal for an older patient to be experiencing pain. Just because you get older doesn't mean you're going to start having pain. We have to treat that. So just because nursing is rough doesn't mean it always has to be. We have to just do proper implementations. Right. I don't know if you want to start a nursing association and start changing some stuff because goddamn.
The Couple Nurses Association.
We need to.
CONA. We're shitting at that, huh?
It's been an amazing episode. I've enjoyed these conversations. Thank you guys for listening on this live stream. I see some viewers there.
Comments. Yeah, Larry, we'll fix the screen next time. Maybe we'll just use a plain one.
Zoom it in. And he said socks. Do you want me to have some
Shoes?
Yeezys on or something? Some nice shoes. We're in a house, right? So
We don't wear shoes inside.
we don't wear shoes inside the house. It's the way I was raised as a Polish person. Polish culture, yeah, where we always take off shoes at the front of the door, and this is like the sanctuary. So we never had shoes on. Yeah. Unless we have a studio, you know what I'm saying? Coming soon sometime, 2021 maybe.
Maybe. All right, guys, thank you for tuning in. Our first live stream. Hopefully you guys enjoyed it. More coming up in the future. And we're trying to get this weekly. We'll see if we can do.
We could do it for sure, and we will.
Yeah. Peace out, guys.